Hello, everyone, and welcome to today's webinar, Recently Updated Hepatitis B Guidelines and What You Should Know About Hepatitis Delta. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Diasorin. To learn more about our sponsor, please visit diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you are having any trouble seeing or hearing the presentation. So with that, I'd like to now welcome our speaker for today, Dr. Robert Gish, Medical Director of the Hepatitis B Foundation. Dr. Gish also holds a few additional titles that can be found in the presenter window. So for a complete biography of our speaker, please visit the Biography tab in that presenter window at the top right-hand side of your screen. Dr. Gish, welcome. You may begin your presentation.
Good morning, Kaylee. Thank you so much. I want to thank Diasorin also for supporting this presentation. And we're going to move through the hepatitis B and Delta world over the next 45 minutes. I do want to identify to everyone, and of course, we'd like to welcome you here for this lecture, that these slides will be shareable, and this will also be a recording that will be available very shortly after the presentation. Some of the slides are quite busy. I'm just going to hit top line information on those slides, and those slides are for your resource and review in the future. So I have some disclosures, of course. Those are at my website. My website also has many resources, and I would encourage you to subscribe to my newsletter. Maybe 4 or 5 times a month, we push out small clusters of new information that I think are super hot topics. The objectives today is to talk about hepatitis B, virology, epidemiology, natural history. We're going to talk about the new move to screen all adults for hepatitis B through the CDC, and of course, wrap that message up with vaccinating all adults who are triple panel negative. We're going to talk about facts and fictions about hepatitis B and hepatitis B testing, very, very importantly. Then we're going to talk about treatment. We're moving into a new model, pending a variety of different guidelines and guidances, to really treat everybody with hepatitis B, to harmonize hepatitis B treatment with hepatitis C and HIV, where it's simple: test all, treat all. Make it very easy. Hepatitis B is phenomenally complex. Guidelines are 36 pages, 400 references, and people sometimes use them for doorstops as opposed to actually reading the details. We'll have a brief discussion about pregnancy and liver transplantation, as well as new treatments, because there's many exciting things coming to treat hepatitis B, where hopefully we can get to a much more frequent level of functional cure. And we'll talk about those definitions. We'll wrap things up with the 5-line guideline. And again, Delta is going to be nested in here. The big message here, and the numbers change a little bit depending on your reference, but I use the number from the Polaris organization that then submits information to WHO. We have 262 million individuals in 2023 that are surface antigen positive. And the data from Robert Wong and my paper in the US is up to 2.4 million. Other numbers have come in the 2 million range. So we're not very far off with these estimates. I believe they're quite accurate. Hepatitis B disease progression. Just think about this. 2 people are dying every minute from complications of hepatitis B. And that number has not changed in 20 years. That's because, depending on the country, between 5 and 20% of individuals are actually on treatment. Many other individuals don't want treatment. The guidelines are gray. They aren't really clear about who should be treated. And treatment is long-term. We don't have finite treatment like we have with hepatitis C. So we have a problem and we have solutions. This talks about that gap. HIV testing and treating, simple rules, many more get treated and tested. Hepatitis C, we're catching up because everybody gets tested for hepatitis C as an adult. And if somebody's RNA positive, they go on treatment. Hepatitis B, I really want to advocate for much simpler guidelines, and we'll talk about through this discussion. This is a DNA virus that replicates through an RNA intermediate back to DNA. So it's a retrovirus, but it starts with DNA, unlike many other RNA retroviruses. There's many animal models of hepatitis B, and this virus lives in the nucleus of the liver cell as cccDNA. It's one of the reasons why we can't get to a complete or sterilizing cure with our current technologies. And also it integrates into the hepatocyte genome and produces S antigen, a truncated S antigen that also can be sort of a decoy in terms of deciding if you're reaching your level of cure. Hepatitis B has a number of impacts: inactive disease, active disease, reactivation, decompensation, liver cancer, liver transplant, and of course, what we talked about, 2 people dying every minute. Patients move between these different phases, and this has been part of the complexity of hepatitis B, but now we have enough data, I believe, to support that DNA positivity equals high risk for a number of these different events, as well as stigma, decreased quality of life, increased infectivity. We have many reasons to make things simple now and change outcomes. We have the data today. This is one of the most important slides in this deck, and I want to have you take home some simple messaging about the triple panel. Surface antigen positive equals current active infection. And if somebody is surface antigen positive, you need to test for Delta with antibody, Delta antibody total, not IgM, and obtain a quantitative surface antigen. That quantitative surface antigen is available through many labs. It's accurate. It goes down to the same sensitivity as the qualitative test. Its FDA status is pending, but this is an LDT at many labs. And as you know, LDT tests often meet the quality or better than the quality that you would undergo for FDA clearance. Next, core antibody. Super important message. Core antibody equals exposure. Exposure to an incurable virus means that person still has cccDNA in their liver. There used to be some fake news about this being high false positive, poor specificity. This is incorrect. In 2002, 2 decades ago, data was submitted to the FDA by a number of the diagnostic companies, and they identified, even in low-risk individuals, the false positive rate of core antibody was 1 in 500 individuals. This is an incredibly sensitive, specific test for the presence of cccDNA in the setting of surface antigen negativity. Surface antibody equals vaccine immunity if core antibody is negative. If core is positive, we use a new term called immune control, and those individuals would be much less probable to have occult hepatitis B and much less likely to have reactivation. Core positive, no vaccine boosting recommended. There's a paper that I wrote that's on my website with a number of great co-authors that goes over all the details and gives you the references about backing this up. Hepatitis B is incurable. There's no natural immunity. That's also fake news that's been out there for a while. There's no healthy carrier of hepatitis B. You have hepatitis B, you are not healthy. And that's why testing, treatment, linkage to care is super important. Next 2 slides, I'm not going to go into great detail. There's a lot of other things we do for a hepatitis B patient. The treatment thing I'm making simple. DNA positive, treat. But we need to make sure they're immune to hepatitis A, they don't have hepatitis C or Delta or HIV. You want to stage their liver disease. You want to determine risk for liver cancer. So this is where B is a little complicated, but you would do similar things for hepatitis C or an HIV patient. The treatment aspect can be made very simple. A little bit more on this, you want to check for fatty liver or alcohol use disorder, talk about pregnancy and counseling, bone health, renal health, super important. Now, this is a diagram from the EASL guidelines talking about new names and old names. I really don't like this word immune tolerant. I think it's out of date. I don't think it's appropriate. It's not accurate. And so we're talking about E antigen positive disease, high replication, low inflammation as chronic infection. Once the ALT goes up, that indicates inflammation. That's chronic hepatitis. You might go to a state where the ALT is normal or healthy again, back to chronic infection. Then you go to E negative as a virus mutates, stops making much E antigen. You're back to a chronic hepatitis with E negative disease. So E antibody, E antigen is still useful to talk about these phases. DNA correlates with long-term outcomes. We have data on cirrhosis. We have data on liver cancer. Once you're DNA positive, the risk for cancer and cirrhosis increases. I could say from this slide deck, from this reference, that this is enough information to say to treat everybody, because we know when you suppress DNA to undetectable, your risk for liver cancer drops 70%, and your risk for cirrhosis drops close to zero unless you have fatty liver, alcohol, or some other type of liver disease, or Delta. We'll talk about Delta in a little bit. This goes back into much more detail about DNA levels and risk for liver cirrhosis. So there's a lot of reference. I'm giving you just a few samples here. We don't biopsy our hepatitis B patients much. Now, if I think they have hepatitis B from testing, they have fatty liver, alcohol, autoimmune, I might do a biopsy to tease out what the dominant disease is in a patient. But I'm not doing a biopsy to stage the patient because I can do this with non-invasive tests. We have excellent data on FIB4. We have good data on FibroScan or elastography tests. There's a number of companies in that space. So stage your patients, utilizing that staging to determine how you're going to do follow-up and if you're going to do liver cancer surveillance. So I really like you to stick with the new terminology. Screening is the first test. Surveillance is ongoing testing. Surveillance, really important term for liver cancer after you determine at risk. Risk-based testing has failed. Very few people have been tested for hepatitis B because all of these risk factors, some of which are stigmatizing, some of which are people just don't want to admit or they don't remember. So we have changed. CDC has stated test all adults for hepatitis B. Triple panel. If triple panel negative, the ACIP says vaccinate all adults. So we have some important takeaways here. If we're going to meet WHO goals for elimination, which we have signed on to, complex guidelines will not get us to this elimination. So just for one specific reason, and we're not curing hepatitis B by 2030, but we are going to decrease risk of cancer and death, and that's part of the elimination guidelines. DNA positive, treat, marked change in patient outcomes. And it's not just a cirrhosis patient. It's not just a liver cancer patient. These people are infectious. They are stigmatized. There's decreased quality of life. There's extrahepatic manifestations of hepatitis B. All of those are improved with treatment or changed. Very complex guidelines here. ALT, DNA, stage of disease. A lot of patients, 40, 50% will fall into a gray zone. And gray zone means I'm confused. The patient's confused. The provider's confused. Let's make it simple. DNA positive. Let's treat. Pregnancy is another important reason to keep that DNA level low in terms of decreasing risk of transmission. We have very good information today, quality information today, to change the guidances or the guidelines. We're asking our leaders to embrace this information and help us go to elimination goals. More on immune tolerant patients, a term I don't like, but I'm going to put it here because it's in so many publications, that these individuals do worse than people who are on treatment. And these are numbers that to me are not acceptable. risk of liver cancer, risk of death or transplant, very high. We know we can markedly change these with treatment. As I mentioned, I quantitate S antigen levels on all my patients. And here it's just the S antigen has a correlation with HCC risk. So let's say we treat everybody, DNA levels are undetectable. Then how do we calculate a liver cancer risk? Quantitative S antigen. It's available through many reference laboratories. And there's other reasons: infectivity, risk for cirrhosis. Are they clearing S antigen on treatment? Are they clearing S antigen without treatment? There's a whole discussion now about when to stop nucleoside or nucleotide, these oral therapies, and surface antigen can help guide those discussions. Just remember, somebody who's infected with hepatitis B or C is the equivalent in terms of cancer risk of somebody smoking a pack of cigarettes a day. These are oncogenic viruses. This has to do with the number of patients outside international treatment criteria, people we wouldn't treat, and the risk of developing liver cancer. It is very substantial. DNA positive, risk for cancer. DNA negative, we're going to reach that by treating these individuals. Marked decrease in risk for liver cancer. A little bit more on why to treat patients. We reduce integration. We talk about integration, making S antigen, but that's that integration that's a component of that liver cancer risk. This is inferential now, but how do we explain the liver cancer risk declining? DNA is low, and we decrease integrants. There's quite a bit of information on that we could have in a separate discussion. This is why to treat everybody, more components. Good suppression, better chance of S antigen clearance. People don't clear S antigen frequently if their DNA is positive. We want to clear S antigen to treat to DNA negativity. And we have great medications. We have 3 first-line medications: entecavir, tenofovir, TDF, and tenofovir, TAF. And we still have PEG interferon in our pocket, although we're rarely using interferon today. But there's some very exciting new medication combinations coming out, including a recent phase 2 study with some molecular treatments and interferon that led to a S antigen loss of 30%. Now, this is preliminary, maybe a select population, but I find these exciting ideas and concepts and ways to move forward. So what have our current therapeutics done? And those are outlined here. I've already talked about all this, but it gives you a lot of information here. And really the only X on here, which I'm going to highlight, is the lack of S antigen loss. That's happening at a 5 to 10% rate. It's not very high, but if you're in the 5 or 10%, you're a very happy camper in those. And that indicates the chance of coming off treatment. A little bit of a build here. We talked about terms: inactive carrier, functional cure, complete cure, sterilizing cure. Now, complete cure and sterilizing cure, I think, are 7 to 10 years away, but we have technology, I believe, today, and this has to move through clinical trials, that will give us a chance of a complete cure or sterilizing cure in a subset of patients. What about stopping nukes, entecavir, tenofovir? This can result in some patients clearing S antigen as you take them off the nuke. They have an immune response. There may be a bump in the viral load, and that immune response and that change in virus may lead to this immune control we've talked about with S antigen loss, and even better, in my opinion, if they're surface antibody positive. And this is dependent on their quant S antigen status. In Asian patients who typically have had disease 2 decades longer than a Caucasian at a same age point, we need to have a lower S antigen level, and preferably under 100 in an Asian patient before you would consider stopping. And we don't stop nukes in somebody with cirrhosis. One of the reasons this is important is that up to 40% of patients stop nukes on their own without telling their provider, or they tell their provider later. So it's nice to be able to map the surface antigen status and see what's happening and counsel patients about something that they may do on their own. TDF, What I'm going to just say on this very complex slide is when you treat with TDF in this very nice study, the amount of expression, the amount of RNA coming off virus, including viral integration, is decreased. So TDF is doing something, helping the immune system, changing the viral dynamics in the cell to decrease what that virus is doing in terms of integration. So the paradigm is changing. We have this current suppressive concept, and we want to change to a much more frequent functional cure and finite treatment. This is coming. We are over 30 medications with over 16 different targets to treat hepatitis B in development today. Every week, actually, I hear about a new drug, medication, technology that could be a component of treating this disease. As we get closer to a wrap-up on B, we have to bring ourselves back to vaccination. And there's been two advances in vaccine. One is called Heplisav B. It's a 2-dose regimen. It's got a very potent adjuvant with a TLR agonist that's built into the vaccine to boost antibody response in non-responders and also to have a higher antibody level in a given normal patient population that would confer most likely much longer protection. And right now we think the vaccines protect for 35 years. This is data from Alaska, data from Senegal, other research. So we think our vaccines are excellent now, but we're now in the super excellent mode, including VBI, which has a 3-dose triple antigen vaccine, also high response in low responders. And we think with these high titers, more durable responses. 12 countries account for over 70% of the global incidence of hepatitis B. And this is one of the reasons that I work worldwide. I'm going to be in Asia again next month. I've been in Asia twice already this year. I'll be in Europe next week for the EASL meeting. This is really important. I want to bring up what happened in China just a few weeks ago. They came out with their new Chinese guidelines, which are a merger of the Hepatology Society, collaboration with infectious disease, collaboration with the Ministry of Health, to state, treat everybody. If you're over 30, you're DNA positive, you're going to be on treatment in China. And this is funded. Funded meaning treatment is paid for through different insurance or national programs. This is a major move. So if the #1 country with hepatitis B in terms of numerical prevalence is moving to treat everybody, and we have data that this is cost effective. So we're not wandering in a dark forest with no flashlight. We have the data today. We're making a difference with vaccine and decreasing prevalence. So the reason I said 30 years in the China guidelines is because under 30, there's been so many people vaccinated that ends up being a case-by-case issue under 30 if you find somebody who's DNA positive or surface antigen positive. So we have this 5x5x5 message, reasons to treat everybody, stigma, discrimination, quality of life, extrahepatic disease, infectivity, chronic liver disease, including cirrhosis, cirrhosis treatment, cirrhosis prevention, and liver cancer prevention. Very simple, 5-line guideline. How to manage those 5-line guidelines is to treat all, but we're going to test everybody, triple panel. Vaccinate everybody who's triple panel negative. Link surface antigen positive to DNA, NAT, nucleic acid testing, whether it's PCR or similar technology, and Delta antibody screening, total antibody. Back to DNA positive, treat everybody with nukes or research trials, and stage patients and decide on surveillance. 5 key messages. This is sort of a wrap up of what we've talked about and how you deliver this message to your patients and to your providers. Final comments, we're only going to reach elimination when we have the rights of all people who are hepatitis B respected and linked to care. This benefit needs to be to the person being tested, and we work with our authorized health services and authorities in this partnership. These people need to receive accurate information, and that's what we've been focusing on today. Let's get rid of the misinformation out there and go to accurate, simple messaging. Five-line guideline and summary is highlighted here. And now we have something very exciting. We're going to move on to D, hepatitis D. D for deadly. Delta, very important virus to be part of what we're talking about. Many of these slides came from this University of Louisville program that I did with the SC Liver Research Consortium, Paul Procros at the Scripps program. Thank you so much to these wonderful CME teams. Nice little picture here of the DNA virus and living with an RNA virus, an interaction. So this is an RNA virus that packages itself not with the DNA of hepatitis B, but with the surface antigen and its own delta, large and small antigens. This is an interesting virus that's related to plant viruses, smallest known human virus, and one of the smallest known viruses in our world today. Over 12 million individuals have delta infection, and D is for deadly. Somebody's delta antibody positive and found to be RNA positive with nucleic acid testing, typically PCR, but there are other options, 70% mortality rate. And I'm taking care of delta patients all over the United States with my telemedicine program and consulting for specialists and consulting for people. And I want to highlight the delta process that Hepatitis B Foundation has moved forward, this Delta Connect. It's very, very useful for you. And please sign up for the Hepatitis B Foundation newsletter and be aware of what's happening in that Delta world. Delta in the US has hotspots. Illinois is a hotspot. New York's a hotspot. Parts of California, including Los Angeles, are hotspots. This tends to follow immigration patterns and behavior patterns. So there's a lot of information on this slide that you can review later. But with projects I've worked on most recently with Gilead, because Gilead's moving a hepatitis B medication through the FDA at this time, huge amount of information going through all payer claims databases has been very, very useful. So I think this is something that's a hot topic. It's been a hot topic for me over the last decade. It's been a big part of my career. And now it's becoming infectious. The interest is infectious. It's bringing a lot of people into this fold. And we need this research so we can bring more data back to the guidances and guidelines committee to also harmonize. Delta RNA positive, treat. That's really where I think we're going to be very shortly as well. Modes of transmission are similar to hepatitis B, but sexual transmission a little bit lower because Delta suppresses B. And when you have less B, you have less Delta infectivity. But it's usually blood exposure, needle sticks, percutaneous. Mother to child is rare, but it can happen. Other risk factors are highlighted here, but it's really going to make this simple. Test everybody for Delta who is surface antigen positive. The antibody test is not expensive. You want to order total, not IgM. Natural history, 70% mortality rate once somebody is chronically infected. It's a little confusing in terms of the terms here because co-infection means you get both infections at the same time, but many of those people clear. You have hepatitis B chronic infection, then you get Delta. That's called a super infection. There are multiple Delta genotypes, but we're not commercially using that yet. In the near future, more research is needed there. And there's variations of Delta by different hepatitis B genotypes. That's a research tool as well. I'm not advocating you genotype your hepatitis B patients in your practice. I don't think that's useful. And it's definitely complex. And it goes against our new simple messaging. A little bit more on this life cycle. And the reason I'm bringing this up here is, well, you can learn some virology, of course. But this NTCP receptor, which is a bile salt receptor that sits on the surface of the hepatocyte, is how hepatitis delta enters the liver cell through this surface antigen attachment. It's a little bit more complex than what this slide shows, but this is that core issue of bringing delta into the liver cell. It then gets transported to the nucleus, replicates, goes into the cytoplasm, gets modified, including prenylation, which is where another new medication coming out called lonafarnib works. So we have bulevirtide blocking entry, and we have another medication being developed by Eiger, where we're changing this prenylation process to inhibit packaging. And once you inhibit packaging, you decrease viral egress from the cell. So knowing this, we can develop new drugs. There's another medication from a company called Replicor that blocks packaging of Delta with some very interesting and profound results that have been published. The disease course, 70% risk of cirrhosis, death, transplant, higher risk of liver cancer that may be double or triple what you see with hepatitis B. When you suppress Delta or B, you have better outcomes. If you suppress both of them at the same time, even better outcomes. Delta tends to suppress B, but any Delta patient with any level of B replication is at higher risk of progression, in my opinion. So all Delta patients should be on a nuke if there's any detectable B, following our simple guidances or guidelines that we talked about before. Worst patient outcomes, this just talks about B versus Delta plus B, and a lot of information. But look on the right side. It's not just about cirrhosis and cancer, but people are worried about cirrhosis and cancer. They have somatic, including abdominal symptoms, and decreased physical well-being, decreased emotional well-being. And when people get treated, yes, you could say there's a stigma of taking a medication. The stigma of the infection, in my opinion, this is both direct assessment and review of the literature, is 10 times worse. So treatment improves patients overall. This just talks about liver cancer and hepatitis B with and without Delta. We already talked about this, and cancer risk is higher and earlier in terms of its onset. Clinical outcomes. This has to do with Delta antibody positive, whether they're Delta RNA positive or Delta RNA negative. That RNA correlates with outcomes, just like Delta when we're having hepatitis B, we look at DNA and outcomes. In Delta, we're looking at RNA levels. And that's why we're really, I believe, moving to treating everybody. Now, the recommendations are a little bit vague because here at AASLD says take a risk history. The risk history assessment has failed in many, many settings. Now, how to test? EASL had no recommendations, but just think EASL guidelines are going to come out soon, and I think they're going to be very clear in the new guidelines. So I'd ask you to sit tight for the EASL program and just take a look at the guidelines when those are published. We've got other guidances, including WHO, which has no recommendation, but how to test. They talk about how to test, but they don't say who to test. But WHO is rewriting their B guidelines, and I'm hoping that Delta will be part of that new guideline. So, or like EASL, I believe, is coming up with a separate Delta guidance, and maybe AASLD may do that as well. Delta has multiple stages. We talked about that. What I really want to emphasize on this slide is the IgM testing for Delta should only be done in very special settings where you directly suspect acute Delta infection, whether co-infection or superinfection. Otherwise, you're going to order Delta total, which includes IgG and IgM, but order Delta total. That's your screening test. Delta total positive, check for quantitative Delta RNA. Super important. Non-invasive tests in Delta work. So I'm just going to show you this slide. You can refer to this later. I use a combination of FIB4 and some type of elastography. Unmet needs. No one's getting tested. This is so terrible. We have guidelines that talk to you about testing. Even the risk-based testing isn't working. Tests also have a problem because they're not available through all of our national labs that we have, or local or regional labs. So we really need to harmonize Delta guidelines, but you have to give people the tools. So I'm going to say this is a call out to all labs in the United States and around the world to offer Delta antibody, total antibody testing. Please bring that to our providers and, more importantly, to our patients. Unmet need, highly fatal, and other outcomes. We need to test and link to care. Within the next year, we're going to have 2 medications, I believe, to be FDA approved. This is very exciting. Recommendations, right now we only have interferon and we can treat the underlying hepatitis B. And if you use interferon, you need to treat for at least 1 year. Follow the RNA level on treatment. It's very important. And if you stop treatment, follow it off treatment. What do we call a maintained virologic response? Is delta RNA negative 24 weeks post-treatment. Whatever treatment you're using, you stop and see if they relapse. I like this term, maintained virologic response, because we can't really cure delta confidently unless we have a functional cure for hepatitis B or beyond. Peg interferon, 1 year to 2 years of treatment. We have somewhere between a 15 and 30% maintained virologic suppression. It works, has side effects, but I found that my B and Delta patients can tolerate interferon much better than my hepatitis C patients. And there's a lot of complex explanations behind that, but that's my experience. When you reduce delta RNA, you improve survival. We have data dating back over 2 decades that support this contention. Mechanisms targeting viral replication, viral entry, viral release. We talked about bulevirtide. We talked about lonafarnib. We talked about the NAPs, which inhibit packaging and release. Immune regulation using, sorry, it's very light touch on the on the slide forward here. Remember, interferon alpha and interferon lambda modulate what happens inside the cell, something called SMAC5, SMAC6. There's other things that are happening where that immune activation changes viral control. Yesterday at the Hepatitis B Foundation, there was this incredible honor to Bill Mason, who is an incredible researcher in this space, with his hepatitis B research also helping our Delta world. So let's move through our conclusions as we move to our Q&A session. Delta, underdiagnosed, but prevalent at 12 million people in the world, 100,000 in the United States. 100,000 people, 70% mortality rate. This is cost effective to screen, especially as we come out with new treatments. And the time to screen is now. Don't wait until we have treatments approved. Get your patients screened as they come back every 6 months for their standard of care testing for their hepatitis B. We need to make sure all of our labs have Delta total antibody testing available, and we can link them to quantitative Delta RNA PCR. Let's make it simple. Surface antigen positive, check for Delta. We need rapid tests. Stefan Urban, one of the most famous people in the Delta world from Germany, does have a rapid test, a point of care test that he has developed. I think that may be carried forward into a commercial setting. I sure hope it is carried forward. Interferon, yes, it's a tool we can use today. I do offer that to patients depending on where they are. Or I may contact Gilead and get them into a compassionate use program for bulevirtide. The trials for lonafarnib are complete in the sense of the first wave, but there's new data of using lonafarnib with gamma interferon, this new form of, lambda interferon, this new form of interferon that's been researched for B over the last 20 years. Lambda is really interesting because lambda has a focus on the liver with receptors and less somatic side effects you might see with standard interferon. There's a major need for new therapies to bring to our patients because providers often don't test and think about treatment unless there is an FDA-approved treatment. I think this is really a lag. I think everybody who has Delta should know, We're going to monitor them more closely, monitor and stage them more frequently. We're more likely to put them on a nuke if they have any level of DNA, of course. So there's a lot you can do for Delta today. So test today. Bring those patients into the system with knowledge as we obtain new tools. The newer therapies have better viral suppression, often can have a reset in their viral load or a viral clearance. I call it the 40-20 rule, that we're really changing Delta levels in about 60% of our patients. Primary care clinicians out there, you play a vital role. Laboratory people, you play a role by making sure you have all the tools for B and Delta in your laboratory today. Hot topics in B is quantitative S antigen. I think every B patient should have a quant test done annually. I gave you the reasons for that justification, but I want to do a wrap up here. Delta, let's get Delta total and Delta RNA quant in every lab setting possible around the world, not just the US. I'm focusing on the US today because that's most of our audience, but this really has to be a global, simple message so we can harmonize our elimination goals. So I think, Kaylee, it's back to you for the Q&A session, and hopefully hit all the hot topics, and hopefully there's some questions coming in from our audience.
Yes, absolutely. Thank you so much, Dr. Gish, for your time and your informative presentation. We will now start the live Q&A portion of the webinar. So if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the bottom left-hand side of your screen, type in your question, click Submit, and we'll answer as many of those questions as we have time for. All right, so our first question here, Dr. Gish asks, when the CDC updates guidelines, what is the process for reimbursement being updated? And for example, with the new HBV guidelines, when is the reimbursement reevaluated now that the triple panel testing is recommended?
Fantastic question. And there's two parts to this. Often when the CDC comes out with a recommendation, many insurance companies will pay for this triple panel screening. And in fact, over the last decade, even before these guidances or guidelines, I've had no trouble getting them reimbursed. But there are insurance companies that are extremely dollar focused as opposed to patient focused. And they wait for the USPSTF to come out and give a recommendation. We're hoping to accelerate that wonderful organization in Oregon to harmonize with the vaccine message and with the testing message. So it's going to be a phase in summary, that this reimbursement problem. So if you're having trouble with reimbursement, contact us at the Hepatitis B Foundation. We're going to look at two parts. We're going to continue to communicate with the task force, but also we'll communicate back to the insurance company to advocate for payment now. So this is not a burden to the patient.
Great, thank you. Another question I have for you here. We are testing patients' HBV with Diasorin liaison XL. I just found out if the platform detects HBV for the first time in a patient to retest the same serology in another platform. Being an FDA approved and cleared instrument, is that a recommended practice?
Well, the good news is, Kaylee, that this is what happens in every lab, that you have a first test that's positive and a second test is done automatically. And you'll see a stipulation that a second test was performed to confirm the first test was positive. So I believe the Diasorin will follow that pathway, but we can ask our medical science people at Diasorin to confirm. I do want to bring up something here because yesterday I was sent a text message, because I get messages from around the world on a daily basis, of somebody who had two tests that were surface antigen positive, but the confirmation test was negative. This happened twice over 3 months. Interestingly, over those same 3 months, core total was negative as well. So we have core negative, but two surface antigen tests that were positive and a confirmatory that was negative. Now I said, well, when did this person get hepatitis B vaccine? And they said, oh, 17 years ago. So there's no recent vaccination. This is probably a false positive surface antigen test, and that's where core antibody really helps you. It was negative. So what we're going to do with this patient is wait another 3 months, test one more time for surface antigen, confirmation, and also core antibody. Now, if we find out that diazorin only really requires one level of testing, that would be a major breakthrough. So we'll follow up with our audience on that.
Great, thank you. We have another question here that does have a few parts to it. And this question asks, did you mention that false positive HBC AB reports, 1 in 500, any concern on HBC IgM only? Recently, we have seen HBC IgM false positive cases more than previously reported. Based on ID request, we suppressed HBC IgM reporting and only HBC total ABS reported instead. Any comments?
That is a super smart person and laboratory and observation. The IgM test has many problems with it and should only be ordered or tested in a setting where you're seeing in front of you an acute hepatitis. Now, what I would say is, how do I define that? An ALT over 200 with or without some recent risk behavior, because this IgM test even can be positive in people with Delta long-term or with hepatitis B long-term, having to do with viral replication or activity or immune activity. So suppressing IgM testing is very important. I did work with Quest about 2 years ago on a process of simplifying what's on their website, and LabCorp followed that, and I think Mayo Clinic as well, to really have IgM testing for B or Delta as a second level testing. It's a test that's behind what you first see for your testing options. And you really have to be thinking about why you would order that test before you would enter that little check mark. 3, 5, 7 years ago, when you ordered a Hep B panel, you got an acute panel. That was the first option. Everybody hit the box, checked it. And most people don't have acute B or don't have acute Delta. That's maybe 1 or 2% of a patient population that's clinically presenting to a provider. And I'm glad we reversed that. So now we have these chronic panels, and you look for acute disease with IgM in this case, only in special clinically appropriate settings. And this is covered in detail in that core paper that I published with Dr. Protzer from Germany. It's available on my website, or maybe we should post that after this and get that out in parallel with this slide deck. Fantastic question. Hopefully we answered each component.
Thank you, Dr. Gish. And it looks like we have time for maybe one more question here. So this next one has some case history behind it before the question is asked. So this case is a 29-year-old, 4 months pregnant HCW, had an HCV needle stick exposure. She was given immunoglobulin. She didn't have any symptoms other than fatigue, which could have been from her pregnancy. Her lab test showed only hepatitis B, SAB 4.75H. Why would she be denied being a good blood or organ donor since she has been in good health for decades afterwards?
So that's a super important question. So HCW is healthcare worker. So you have looks like a 29-year-old woman, a healthcare worker, needle stick exposure. And that needle stick exposure may be why she was screened out as a blood donor, not her laboratory testing. But you posted the surface antibody test at 4.75, which is really borderline positive. I would really need to know her core antibody status. And if she's core positive, then that's also a reason she would be screened out. So the blood banks and organ donors take risk history into account, and they look at a wider panel of blood tests. What is her current hepatitis C antibody status? I need to know her hepatitis B triple panel to answer this in more detail.
Great, thank you. And we did get another question pop in about that paper that you were just referring to, Dr. Gish. So maybe we can have, if anyone would like to receive that paper, they can reach out with a question and you can follow up at a later time there to provide that link to that paper.
Yeah, I'm going to email to your team that paper, then you can post it on the website alongside the PowerPoint of this lecture.
Perfect, that sounds great. We'll go ahead and do that. We have time for just a few more questions here, so we'll go ahead and wrap up just after this one. So Dr. Gish, this last question asks, can you please explain HDV association with HBV SAG, the mechanism of RNA versus DNA mix?
Okay, I think there's really two parts to this. So Delta is an RNA incomplete virus that uses host enzymes and hepatitis B replicate and package and release. That RNA attaches itself to the surface antigen. I think it's typically the large and small surface antigen. It has its own large and small antigen. That means Delta has a large and small antigen that allow attachment and carriage inside that surface antigen, plus some membrane to be carried. And that's just how the virus has survived over the last, I don't know, we don't know how long Delta's been in humans. We know B has been in humans for 40,000 years. Delta, not quite so sure how long that's been, but this incomplete RNA virus requires the DNA components and host enzymes for replication and infectivity. RNA versus DNA. So that's the second question. Delta RNA, as it's replicating, suppresses and takes over some of the B machinery. So B is not replicating as much in the setting of a Delta infection. So Delta suppresses B replication for its own utility, for its own survival, for its own replication. Very clever virus, incomplete virus, tiny RNA virus from plants that uses hepatitis B to carry out its full replication and infectivity cycle.
Wonderful. Well, thank you again, Dr. Gish, for your time today. That will conclude our Q&A session. I do want to reiterate one more time for our audience here that that paper that was referred to by Dr. Gish will be added to the interface that you're looking at now. So you will receive an email from LabRoots letting you know that the webinar will be available to view on demand. As soon as you receive that email, you can jump back into the studio and click on that link to obtain that reference that Dr. Gish provided us here. So Dr. Gish, again, thank you so much. Do you have any final comments for our audience?
I do, and thanks very much for having me, the Diasorin team for putting this together, LabRoots for really working together collaboratively to get this condensed presentation. There's so much information out there. And remember, new guidances are out there, new guidelines, recommendations. Test all adults for B with the triple panel negative, vaccinate, really correct some of the messaging from core antibody that this test has a high false positive rate. That's wrong. If you see core, educate about reactivation risk, educate about occult hepatitis B. That means core positive, surface antigen negative. Check for DNA in those patients. You may find people who have occult hepatitis B. Don't vaccinate those people. That's a waste of time and resources with no clinical benefit. And Delta, D is for deadly. We have testing available, and I believe in the next few months, everybody in the United States will have access to Delta total and linkage to Delta quantitative RNA. And keep your eyes open for new B treatments and new Delta treatments. There's a lot of exciting things happening in this wonderful space. Fantastic. Thanks for having me. And we wish you all to have a really nice summer, but let's work hard on B and Delta elimination together.
Absolutely. Well, thank you again, Dr. Gish, for joining us today in your very important research. We would also like to thank LabRoots and our sponsor, Diasorin, for underwriting today's educational webcast. Now, before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.